All right, everyone, good afternoon. Thank you for joining us for the Ask a Radiologist webinar series. Before we get started, I'm going to share some housekeeping items for today's webinar. Everyone on the call will remain muted for the duration of the webinar. At the end of the webinar, we will open up the floor for a live Q&A. We encourage you to ask questions, and you can submit your questions at any time using the chat box feature in the Zoom platform. For today's webinar, we are joined by Dr. Amy Chudgar. We also have one of your physician liaisons, Travis Roseborough, on the phone. If you have any needs regarding patient education, referral forms, or other materials, Travis or our other physician liaison, Antonio, can stop by your office for a visit. I'd now like to introduce our speaker, Dr. Amy Chudgar. Dr. Chudgar is a radiologist with Charlotte Radiology and is subspecialized in breast imaging and nuclear medicine. After completing her residency at the hospital at the University of Pennsylvania, she completed a fellowship in breast imaging at Memorial Sloan Kettering. I will now pass it over to Dr. Chudgar to begin the presentation.
All right. Hi, everyone. Thank you so much for joining. So today I'm going to be talking about breast density, and we're going to talk about breast cancer screening and how these relate and how that influences what type of screening patients should be getting. So our goals and objectives for today's discussion are to talk about breast density and its significance. I will talk about conventional 2D mammography versus digital breast tomosynthesis, also known as 3D mammography. And then we'll talk about supplemental screening options for women who have dense breast tissue, who may or may not have risk factors, including screening breast ultrasound, breast MRI, and abbreviated breast MRI. And then at the end, we'll talk about the recommendations for screening. So just an overview about breast cancer. As we all know, 1 in 8 women will be diagnosed with breast cancer over their lifetime. 1 in 39 women will die from breast cancer, and it is the most common cause of cancer in U.S. women after skin, as well as the second leading cause of death. So 1 in 6 breast cancers do occur in women in their 40s, and these cancers are often more aggressive than those diagnosed in older women. So this is why it is so important that we do begin screening mammograms in all women beginning at the age of 40, if not earlier. And then what's also important to know is that most breast cancers, so 85%, are actually sporadic and occur without any known family history. So again, this is why screening is extremely important. We really don't know who breast cancer will affect, and so we have to screen everybody. So we're going to first talk about screening mammography 2D. So screening mammograms have been shown to decrease mortality by 20 to 40%. And the cancer detection rate, or the CDR, is 5 cancers detected out of 1,000 women screened. So the goal of screening is really to detect cancers while they are small and before they are palpable or symptomatic. So that essentially translates to detecting them at an earlier stage while they are still small and before they have metastasized. And this results in less extensive treatment and improved prognosis. Screening mammograms are cheap and they are a quick exam. So I'll start with an example. This is a 44-year-old woman undergoing a screening mammogram. We will talk about breast density, but she has fatty breast tissue, and she was recalled for these 3 masses or small nodules noted in her upper outer quadrant. And this is a corresponding ultrasound when she came back in for her workup, where we can see these irregular hypoechoic masses at the 11 o'clock region. These were biopsied, and this did show a triple negative invasive ductal carcinoma and ductal carcinoma in situ. So this was essentially a pretty aggressive breast cancer that was caught early. However, the biggest limitation of screening mammography is that it is limited in women with dense breast tissue. And of course, there is radiation exposure, although it is a small amount. So let's talk about breast density. So breast density refers to the amount of fibroglandular breast tissue that is seen on a woman's mammogram. What's important to know is that breast density is not actually referring to how a woman's breast feels on a clinical breast exam. It's really, this is a mammographic finding. And so breast density So fibroglandular tissue appears white and then fat appears black on a mammogram. And so this is kind of showing you the range of densities. And this is somebody who has a lot more fat, and this is somebody who has a lot more tissue. So we do categorize the breast density into BIRADS categories. So BIRADS is a reporting system that we do use for standardized language and breast imaging. So BIRADS stands for Breast Imaging Reporting and Data System. We use this not only for mammograms, but also for all breast imaging, so ultrasounds and MRI as well. So part of BIRADS is that you do have to report the breast density, and that is divided into 4 different categories. So we have category A, which means the breasts are almost entirely fatty. So you're going to see mostly black, so mostly fat. B is going to be scattered areas of fibroglandular density. So we have some more increasing density. C is the breasts are heterogeneously dense, which may obscure small masses. So we are getting denser. And then D is the category where the breasts are extremely dense, which lowers the sensitivity of mammography. So this is a standardized language that you'll see in the reports. So 10% of women fall in the fatty category, and then 10% fall in the extremely dense category. So the majority of women, 80%, are going to fall into these mid-range categories, so either scattered or heterogeneously dense. And women are considered to have dense breast tissue if they either have the heterogeneously dense or extremely dense breast tissue. So you can see that this is going to be 50% of the population is considered dense. And when we determine the breast density, this is actually going to be determined subjectively by the interpreting radiologist. We do use some software, it's called Volpara, which does determine the mammographic density volumetrically. So it does give a more objective quantitative interpretation, but it's not perfect and it isn't always accurate. So the final density is determined by the interpreting radiologist, and there can be some variability from year to year. So that's why you may see a different density categories from year to year, especially if they're somewhere, you know, in the middle of the densities. Now, the reason that breast density is so important is because of its masking effect. So, you know, we talked about how fibroglandular tissue is white, and cancers also appear white on a mammogram. So trying to detect a white breast cancer in an increasingly white background becomes more of a challenge and limitation. So the more dense that the breast tissue is, the more likely the mammogram will appear normal, even if there is a breast cancer present. So essentially you're going to have increased false negatives. This also leads to diagnosing more interval cancer. So it essentially means that the cancer is not detected on the screening mammogram, and the patient will present sometime within the following year, now with a palpable concern or some type of symptom. And interval cancers are associated with a worse prognosis. Breast density itself is also an independent risk factor for developing breast cancer. So when you compare somebody who has extremely dense tissue, they have 4 to 5 times relative risk of developing breast cancer compared to somebody with a fatty breast, and 2.1 times relative risk factor compared to somebody with an average density breast. So as an individual, just having dense breast tissue is not as important of a relative risk factor, such as having a genetic mutation, so having a BRCA mutation or having a history of atypia. But the reason that it matters is that it's just so common on the population level. Breast density such as, and family history are both important because they are just so common. So, you know, we talked about how screening mammograms are very helpful, but they are limited by breast density. So this kind of led to the development of breast digital tomosynthesis, also known as 3D mammograms. So with 3D mammograms, essentially you're having an X-ray tube which moves across the breast in a 15-degree arc, and it'll take multiple low-dose images at different angles. So it creates these projection images, and then a computer algorithm will reconstruct these into 1 millimeter thick slices. And so as a radiologist interpreting the images, we can scroll through these like a CT scan almost. We also, so doing just a tomosynthesis image has the same amount of, essentially the same amount of radiation as doing a 2D image. In the past, we were doing a 2D image and a 3D image, so you're doubling the dose of radiation. But we have since, and most places now use a synthesized image where the 3D image is used to create a 2D image. So now you're back to the same amount of radiation as you were with a 2D essentially. And the other thing I think that's important just to tell you guys is that we do, for all of the patients that come through Charlotte Radiology, they all do get 3D mammograms. You don't have to request it. That's just the standard. Patients actually have to opt out of getting a 3D mammogram and sign a form that they do not want it. Otherwise, they're going to get a 3D mammogram. From what I understand, about 99% of people's insurances cover it. So that's why we do this across the board. So the reason, what the studies have shown with comparing 3D mammograms compared to just 2D mammograms is that there is an improvement in cancer detection rate, in particular invasive cancers. And of course, those are the ones that we really want to detect. So we're having an increased cancer detection rate of 1.2 to 4.6 per 1,000 screens. And then the other really important factor with this is that it does reduce the number of false positive recalls. So it's going to help us decrease our recall rates, where before we were often calling back people for areas of dense tissue, but now with the 3D imaging, we can just, we are able to know it's just dense tissue, that there's nothing abnormal, hiding in the dense tissue. So we have improved specificity. So here's an example. This is a 51-year-old patient. So she has heterogeneously dense tissue, so she's going to fall into the C category. So she had a screening mammogram and she was recalled. On the 2D images, it would really be hard to see any abnormality. But when we scroll through the 3D images, we can see this spiculated mass in the lower outer quadrant. And the corresponding ultrasound shows this irregular mass. The patient did undergo a biopsy, and this demonstrated an PR positive, HER2 negative invasive ductal carcinoma. So using the 3D image with women who do have dense breast tissue has been found to be very helpful for both dense and non-dense breast tissue. However, the greatest gain in having the improved cancer detection rates and reducing recalls is actually women who are going to fall into that C category, the heterogeneously dense. But there still are limitations of women who fall into the D category, or the extremely dense breasts. And so that's where talking about supplemental screening is particularly helpful. So there's three main supplemental screening options. So there's screening breast ultrasound, and there's the full diagnostic breast MRI, and then abbreviated breast MRI. So we'll start with screening breast ultrasound. So screening breast ultrasound is where essentially we have a technologist who is going to do a very detailed ultrasound of both breasts. And again, these are all supplemental. So these are going to be screening modalities that are done in addition to somebody who's had a screening mammogram. The benefits of the screening breast ultrasound has been shown to have an increased cancer detection rate of 1.8 to 4.6 cancers per 1,000 women who are screened. And when these have been found, they are, again, being found early, so they're node negative, so there's no involvement of the lymph nodes. Some of the benefits of screening ultrasound is that ultrasound is widely available. It is relatively inexpensive compared to other imaging modalities. With ultrasound, there's no radiation, there's no IV contrast agents needed, and it is not limited by breast density. However, some of the limitations is that there is an increase in false positive findings. We are often seeing incidental nodules or findings that are benign and either end up requiring follow-up or biopsies. So that also results in a high short-term follow-up rates. And this is something that is very much operator dependent. So you need to have people who are very well trained in doing this, and it can take a long time. We usually have an hour time slot for each patient because it does take a while to do a thorough evaluation with ultrasound. So this is an example from our institution. This was a 54-year-old patient. She was having screening ultrasounds because of her breast density and because she had a strong family history. So she had a mammogram done 6 months prior, which was negative. And when she had her screening ultrasound, this incidental irregular hypoechoic mass was noted at the 3 o'clock region. She did undergo a biopsy, and this was an ER-pure positive invasive lobular carcinoma. So now we're going to talk about contrast-enhanced breast MRI. So with MRI, it is the most sensitive modality for the detection of breast cancer. The increased cancer detection rate is 15 to 20 cancers per 1,000 women screened. So we know that MRI is a lot more sensitive than 2D or 3D mammogram or ultrasound, and even mammograms and ultrasounds together. And MRI is not limited by density, and there is no radiation involved. However, there are limitations with MRI. So we do get false positives. So again, we're going to see additional findings that are benign. Of course, MRIs are very expensive. It is a long exam, and it does require the patients to be able to hold still and not have claustrophobia. It can be expensive and has inconsistent insurance coverage. And there is limited access to MRIs. For example, at our institution, we have one breast MRI over at MMP, or the main campus. So according to the ACR appropriateness criteria to undergo a full MRI, so high-risk women should be getting yearly MRIs, which is going to be any woman with a greater than 20% lifetime risk of breast cancer. So women who have BRCA mutation or other genetic mutations, or women who've had chest irradiation between the ages of 10 to 30 years old should be getting annual breast MRIs. And this is kind of a long list of people who may fall into these categories. So lots of gene mutations, history of radiation, and then some family history. So this is an example of a 46-year-old who had a left excisional biopsy for flat epithelial atypia, and she had a negative mammogram, and she was undergoing MRIs because with the history of atypia, I believe with the strong family history of breast cancer, she did fall into that greater than 20% lifetime risk. So she had a breast MRI, and she was noted to have this tiny 5-millimeter enhancing focus in the right breast. So she did undergo an MRI guided biopsy, and this was an ER-pure positive, HER2 negative invasive lobular carcinoma, so detected very early. So now we'll talk about abbreviated breast MRI. So abbreviated breast MRI is basically performing a breast MRI, but it's much shorter than doing a full MRI. Multiple studies have confirmed the equivalent accuracy of an abbreviated MRI versus the full protocol. It is a lot faster acquisition, so it's about 6 to 10 minutes compared to a full protocol, which takes 20 to 30 minutes. It is more cost effective. So at Charlotte Radiology, the abbreviated MRI costs $399. And just of note, it is not typically covered by insurance, but it is, compared to a full breast MRI, significantly cheaper for most patients. It does have a shorter interpretation time. We're doing less sequences. And it does have a significantly higher cancer detection rate compared to doing 3D mammograms or ultrasounds. There are limitations with this. Of course, there's always false positive results, and some cancers can remain difficult to diagnose on MRI, so DCIS is particularly one of them. It does require contrast, and again, there is limited access, and then any issues that people have with MRIs, claustrophobia, pacemaker, all of that, would limit their ability to get an abbreviated breast MRI. So this was kind of the big landmark study looking at abbreviated breast MRI in women with dense breast. So this was an Akron trial published in JAMA in 2020. So they compared screening abbreviated MRIs compared to 3D imaging. And what's important is this was just an average risk women who just had dense breast. So no family history, no genetic mutation, just average risk women. This is a multi-center comparative cross-sectional study at 48 centers. And they found that abbreviated MRI did have a significant higher rate of invasive breast cancer detection compared to 3D imaging. So the abbreviated MRI detected 15.2 cancers out of 1,000 women. versus the 3D imaging detected less than half of that, so 6.2. So we started doing abbreviated MRI and Charlotte Radiology, I think around this spring or this past spring or summer. And the people who would qualify for this are going to be patients who are average risk. So they have a less than 15% risk of lifetime risk of developing breast cancer, or they fall into the intermediate risk category, so 15 to 20%. And they have dense breast tissue. So they can have a family history, but again, their risk should not be greater than 20%. If they are greater than 20%, they should be getting the full protocol MRI. Patients must have a mammogram within the past 12 months. As I said, this is a supplemental screening. It does not replace mammograms. If you do decide to have a patient undergo this, they do need an order from their physician. And some of the reasons we should never be doing abbreviated MRIs would be for somebody who has a new cancer, and the MRI is being done for extensive disease. That should be a full MRI. Someone who's status post neoadjuvant chemotherapy, if they have any kind of new concern, so they have a lump or bloody nipple discharge, or if there's kind of any concern with their implant. So those should all just be your full protocol MRI. So in summary, this is comparing the 4 different types of modalities. So a 2D mammogram will detect 2 to 7 breast cancers out of 1,000 women screened. And then adding 3D image will increase the numbers of cancers detected from 0.5 to 2.7. Adding screening ultrasound will increase 1.8 to 4.6 cancers detected. And then abbreviated MRI will increase that to 15.5 to 18 cancers detected. So just kind of some of our main points here. Screening mammography reduces mortality by 20 to 40%. And the greatest benefit is starting at the age of 40 with annual screening. If patients have a strong family history, especially family history of family members being diagnosed at a younger age, then we are seeing patients starting at the age of 35 or potentially even younger. So out of all women, 50% do have dense breast tissue, and dense tissue can limit the evaluation on mammograms. 3D imaging does detect more cancers, particularly invasive cancers, and helps to reduce recalls compared to 2D mammograms, although the 3D mammograms are limited in women with extremely dense breast tissue. And so women who do have dense tissue can benefit from supplemental screening, namely abbreviated MRIs or screening breast ultrasound. And so our screening recommendations at Charlotte Radiology are to do annual 3D mammograms annually beginning at the age of 40 or earlier if risk factors. Abbreviated breast MRI annually for women with dense tissue who may or may not have risk factors, but their lifetime risk should not exceed 20%. If it does exceed 20%, then they should be getting a full protocol breast MRI. And then screening breast ultrasound annually for women with dense tissue who cannot undergo abbreviated MRI. And then the mammograms and supplemental screening, so either MRI or ultrasound, should be staggered at 6-month intervals. So these patients are getting imaging done twice a year. So these are my references, and I have my contact information here. And so I think I'll open the floor up for any questions.
Thank you so much, Dr. Chudgar, for a great presentation on breast density and breast cancer screening. We'll now open the floor for Q&A.
Dr. Chudgar, this is Travis. I've had a couple of providers who have ladies younger than the age of 40 with questions and issues. What is the recommendation for those ladies?
So any patient who has a breast concern should come in for imaging. So if they have a lump, or if they have a clinically palpated lump or a nipple discharge, for all those reasons, they should come in for breast imaging. If they are 30 or older, they will almost certainly get a bilateral mammogram with ultrasound, and that's kind of done, at all, most academic centers. People will use the cutoff age of 30. If they're younger than 30, we'll typically start with ultrasound. And if they're pregnant, we'll also start with ultrasound, regardless of their age. If they are just interested in screening, then they can absolutely do that. They can just have a screening mammogram done. I think many insurances will cover that. I think it just depends on people's insurance.
Thank you. We have another question.
Hi, this is Dr. Freeman. The question I have is, if you have a patient that has atypical ductal hyperplasia with no real significant family history other than, maybe aunts or cousins, et cetera, what is the recommended screening for that besides yearly 3D mammogram?
So I think it just depends on their lifetime risk of breast cancer. So if they don't, if they don't have an elevated risk, then we are just doing screening mammograms. If they have a history of ADH and they have dense breast tissue, they certainly could be getting supplemental screening. Some women who have a history of atypia and dense breast may still end up being greater than a 20% lifetime risk, and they technically should be getting the full protocol MRI yearly. And so oftentimes, if they have a history of atypia, they'll see one of the breast surgeons, and then they usually will kind of guide them and let them know what type of screening they should be getting in the future.
Thank you, Doc. We have another question.
So one of my nurses is asking a question, and I think it could be kind of a two-parter. The first is, if you have a patient that has a lot of breast tissue in the axillary region, what is the screening process for that area? And then secondly, obviously, if you find a lump in that area, what is the workup for that?
Yeah, so having breast tissue in the axillary area is very common, just because that's kind of part of the embryological development. So the axilla is included in the mammogram. It really depends on the patient's kind of mobility. We do try to include as much of the axilla as possible. So just doing yearly screening is completely fine, even if they do have significant tissue in their axilla. However, if they do feel, if the patient or if the referring physician feels a lump, then they should come in for a diagnostic mammogram and ultrasound. So we would do a mammogram and then also ultrasound the area just to confirm that there's nothing else abnormal or no enlarged lymph nodes.
Thank you.
All right, well, if there's no more questions, I'd like to thank Dr. Chudgar and everyone else on the call for joining. A recording of today's webinar will be emailed shortly after.
Great, thanks everyone for joining.
Thank you. Have a great day. All right, thank you.